oftentimes there's a fair amount of anxiety about having the scope in there and in the injections. And I explained to patients, it's amazing to me how many patients, after I'm finished with the procedure, said something like, oh, I worried myself over nothing, or that wasn't a big deal.
It's funny you mention that, Dr. Kim, because that's the most common expression I hear as well after the procedure was, oh, that was it, that wasn't so bad after all.
So today we're going to talk about chemo denervation, or Botox for the bladder. And whenever we mention Botox, a lot of patients associate that with use for cosmetic reasons and smoothing out wrinkles like in the forehead. But how can we use Botox in the bladder for patients who have urgency, frequency of urination, and leaking sometimes when they have an urge to urinate?
Yeah, so Botox is a great medication to use for overactive bladder because, as we are familiar with, Botox, it relaxes the muscle, and the bladder actually is a muscle. And so by depositing Botox in the bladder, it relaxes the bladder muscle. It really decreases that pathologic, unwelcome desire to pass urine. And it really is very, very helpful in treating patients who have urgency, frequency, and this experience of leaking urine because they can't get to the bathroom quick enough.
How do you typically explain it to your patients?
Well, as Dr. Weisbart said, I talk about how it relaxes the muscle and how the bladder is one big muscle, and a lot of times it spasms out of control, causing symptoms of urinary urgency and urgency urinary incontinence. And I think they understand the concept of bladder relaxation, and it's no different than when we use it for migraine headaches, muscle spasms, or wrinkles.
Yeah, similar to that, if the bladder is squeezing uncontrollably and giving you fake urges, I'm trying to make that fake urge go away. So it actually tells you when you have a real urge, so you're not going to the bathroom all the time.
Yeah, that's a great way to explain it. Can each of you walk us through the actual procedure, what you explain to patients in terms of what they expect to feel in the office, what they expect to see, and how effective Botox is in terms of its timeline of efficacy?
Yeah, when I counsel patients about Botox, we usually talk about the whole process. I usually talk about the efficacy. I think it works probably about 75–80% of the time. We talk about the length of duration, which is on average about 6 months. I tell them they'll come to the office. We start by filling their bladder with numbing medication. They'll sit there for a few minutes, and then we put a scope in, and we inject a few sites with Botox. And I tell them the actual procedural part is probably about 2 minutes. Most of it is waiting time for the anesthesia the local anesthesia to set in.
Yeah, similar to that, we can either do it in the office or in some patients who have more pain syndromes. I will do it in the operating room with some sedation. So there are 2 ways we can do this. If you're in the office, we take a small scope that is much smaller than the size of the urethra. We look in the bladder, just make sure there's nothing else in the bladder that I'm concerned about. And then through the camera, we inject in a few different spots. I know Jason does 4 spots, I do 10. And it depends on the dose of the Botox, but they do feel, some patients, especially towards the mouth of the bladder, can have more pain, can have more discomfort. So we do give you numbing medicine to kind of help with that. And it, like he said, it takes less than 2 minutes. And then once the scope is done, we take it out. We just need patients to pee. I do give them 1 dose of antibiotic before and 1 dose after. It's sort of, not as bad as most people think it is. But the most important thing with Botox that really upsets people to hear is that it lasts only 3 to 4 months. And so it is something you need to keep coming back for.
Yeah, and I really stress, Dr. Kapoor, how many patients actually come back sort of as a testament to how easy it is to perform the procedure, how quickly it takes to deposit, Botox into the bladder wall, and how, compared to other procedures, it's relatively, not that uncomfortable. And I really stress to patients that, overactive bladder is clearly a lifelong condition. Unfortunately, there is no cure, and this is one of the best therapies, we have. That is relatively easy to use to get them relief for up to 6 months to even up to a year sometimes in patients.
I find that when I talk to patients about Botox injections, particularly in the office, oftentimes there's a fair amount of anxiety about having the scope in there and in the injections. And I explain to patients, it's amazing to me how many patients, after I'm finished with the procedure, said something like, oh, I worried myself over nothing, or that wasn't a big deal. But patients don't really understand till they've gone through it. You know, they worry about the needles and things like that.
Yeah, it's funny you mention that, Dr. Kim, because that's the most common expression I hear as well after the
Yeah.
procedure was, oh, that was it? You know, that wasn't so bad after all.
Actually, I have a question for you. What percentage of your cases are you doing in the OR, like under sedation?
I think it depends on the patient.
Sure.
Some of our patients, I work in a cancer center, and they have gone through a lot, and they've been radiated. They have a lot of pain. They can present with a lot of pain. Those patients, I would not attempt to do it in the office
Okay.
because I just don't want to challenge that. So I would say maybe 20% or so. But if we do one round, I do about 50% men, 50% women. I do feel like the women tolerate it a lot better than the men, in my experience. Maybe because it's childbirth. But the men, if they're having a lot of pain with the procedure, we are more than happy to do it with some mild sedation.
Because personally, I'm doing about 99% in the office. I'm doing it in the office unless there's a real reason not to, and I find patients tolerate it fine.
Yeah, I think it's funny you mention that because even in patients who I have performed Botox injection in the operating room, after a session or two, I actually try and transition those patients to the office because of just how quickly it can be done and how relatively simple it is.
Yeah, oftentimes with needing to do it in the OR, there's additional preoperative prep that's required, and it takes much more time than just doing
It's
it like
not
a regular
nearly as
office
efficient,
appointment.
right?
Exactly, yeah.
Absolutely. I think you just have a shared decision-making conversation with the patient about what works for them. If they're willing to go through the extra paperwork and the pre-op anesthesia to get some of that sedation, then so be it. There are other procedures like Bulkamid that I used to do in the office all the time, and I felt like patients were so uncomfortable. And so I've transitioned a few of these procedures to do under sedation, and I found that patients just are more comfortable and, makes me happier.
So as much as we can reassure patients about the benefits of Botox, we also need to talk about some of the risks, and there are a couple of risks that we need to make known. One of those is incomplete bladder emptying, as we know, or sometimes urinary retention. How do each of you counsel your patients in terms of being prepared for that risk? Is there any teaching that you do ahead of time? What is your talk track when you let them know?
Well, I review some of the data, and I tell them that there is a chance of urinary retention, and that if that's the case, they may need to learn how to perform intermittent catheterization. But I stress to the patients it's quite low. And also, I think there's a fear that they would just not be able to urinate, but we very rarely see that. We see more incomplete bladder emptying, and I do advise them in a small amount of cases that they may need to learn. I do think one thing I talk to patients about is I think there's more data on kind of different ages, and I think the younger patients have a much lower rate of urinary retention. And I also tell the story that occasionally patients who've gone into retention ask me to put them into retention because they prefer to catheterize and control their life as opposed to leaking.
I think like everything else in medicine, there's always a risk-benefit analysis, and I really try to explain to the patient that, of course, I wish the risk of urinary retention was 0%, but that's just not, unfortunately, the case. But then we talk about how bad their symptoms are, and we discuss, what would it be like for them to give up the opportunity to have improvement in their urinary symptoms because of a, I would say, relatively rare event, something that happens less than, I would say, 5% of the time, needing a catheter after the Botox injection. So we really talk about just the data and just the overwhelming likelihood that the Botox injection will be helpful to them rather than harm them in any way.
So there's multiple categories of patients. In women, yes, the risk is about 5%. I would say less than that. I totally agree. It's mostly incomplete bladder emptying. I've almost very rarely seen somebody go into complete retention. Mm-hmm. So there are patients who will tolerate high post-void residuals for a while if they're doing okay, unless they develop urinary tract infections or they're having more worsening symptoms. And as we just talked about, the Botox does wear off. So this is not a permanent state. As far as men is concerned, we actually went back and looked at our own data. There's, again, 3 categories of men, generally men who are post-prostatectomy. Their anatomy and their outcomes are very similar to women. So we noticed in our data that the risk of incomplete bladder emptying was about 3%, again, in that data. So that's a group I'm very, very happy doing Botox for. In fact, 30% of men post-prostatectomy will have storage symptoms, which is not something maybe we talk about as much. But
we should.
Yeah, there we go. So that's a group I'm very comfortable with. There are men who've just had radiation to the prostate with no prostatectomy. So they have a prostate in situ. That group I'm a little bit more tenuous with. We found up to 30% risk of some kind of complication, either a urinary tract infection or incomplete bladder emptying or actual urinary retention in that group. So that is a group that I will very conservatively discuss Botox on. And then there's this middle group of post-prostatectomy and radiation incontinence. And that group was somewhere in the middle. About 10% of those patients, no retention, but they had a lot of urinary tract infections. The other big group that I have is patients who have an artificial sphincter, but are radiated and so have compliance issues and storage issues with their bladder, men. So that is another group. We just go through the sphincter and apply Botox, and that's another group that does really well with it.
I want to ask you guys one question. Do any of you make patients learn intermittent catheterization before the injections? Because I've been around long enough since the original FDA approval, and that used to be the paradigm in a lot of practice. And to me, that scared away a lot of patients. The rate is so low that we don't bother. Have you ever done that or heard of that before?
I've definitely heard about it before, and actually when I started practice, I think that was the standard, at least to offer patients the opportunity to learn how to perform self-catheterization. Based on the idea that should they experience retention, they would be better prepared. But then, of course, when we look at the data and see that it's not a common event, you'd be exposing quite a few number of patients to the need to undergo catheterization and just the training, the timing, the discomfort associated with it for no reason at all.
And quite frankly, scaring patients away from this good
Absolutely.
therapy.
Definitely.
Between all of the therapies that are available for overactive bladder, between non-invasive therapy, medication, sacral neuromodulation, and PTNS, how do you counsel patients on how Botox might help them versus another therapy?
What I really like about Botox compared to other therapies is that it's very, very easy for patients to understand. They might be familiar with it, because of either their friends using it for whatever the indication, might be. And compared to some of the other therapies that require either very, very frequent visits or the need for anesthesia, it's a relatively more straightforward procedure. When I talk about other therapies and on the medical side of my decision making, I also really try and think about how well the patient is emptying their bladder. We have many patients who might have a lot of urgency and they might have a very, very strong desire to go. But some patients might also have, paradoxically, a difficulty emptying their bladder. And so I use just my medical judgment in those patients, if they also have emptying problems, to decide whether or not that patient is a good candidate for Botox or any other alternative therapy.
So I think the American Urological Association with SUFU came out with a really nice guideline. So we have a patient handout that kind of goes through it. We first talk about lifestyle changes, avoiding bladder irritants, coffee, tea, sodas, artificial sweeteners, fruit juices, alcohol. I can roll it off my tongue because I say it so many times during the day. And we have them fill out a bladder diary and we point, look, there. Don't drink this, you won't pee so much. We talk about pelvic floor physical therapy. I'm a big proponent of that. We usually try offering medications as well. The new paradigm shift is that we don't have to have patients do physical therapy and medications before trying Botox. We present all the options to them at the same time. So if they're like, I don't want all the systemic side effects from these medications, I would rather do something that's localized directly to my bladder, then we go directly to either Botox, PTNS, implantable tibial stimulation, or implantable sacral stimulation, and also local vaginal estrogen therapy. So we present all the options. A lot of our patients are traveling back and forth. They don't like the 3-month, back and forth. So I think that's one thing that turns people a little bit away from Botox versus the tibial and sacral, which is kind of a one and done in some ways option. So it just depends on the patient. We just kind of lay out all the options with the risks and benefits and let them choose.
Yeah, I agree with everything you said. The latest update for overactive bladder for the AUA and SUFU really also talks about, like you said, non-stepwise progression. Unfortunately, the reality of the situation is insurance still dictates what we do. As much as we'd love to jump to these procedural interventions such as Botox injections, we can't right away because it's insurance companies. For example, I think now for Medicare, Botox says they have to fail 12 weeks of either behavioral modification or medication or both. So it is a little limiting, but let's say they've met the medical necessity when it comes time to talk about procedures. It's all about shared decision-making, which was also a big update in the AUA guidelines. I talk about all the therapies, Botox, PTNS, sacral neuromodulation, implantable tibial nerve stimulation. And you can get, with that conversation, you can get a feel where patients want to be. Like you said, actually, we're all from the metro New York area, and we have a lot of patients that go to Florida for the winter.
Yes.
And so in that case, Botox may not be the best therapy, or I have some patients who get Botox in New York in the winter, and then in the summer they have a physician in Florida. If they don't have transportation or can't come to the office, Botox might not be great. If their manual dexterity is not good, they may not be a good candidate. So there's a lot of little factors that affect how you talk about it.
Yeah, I talk about it the same way with my patients, and I think similar to Dr. Weisbart, if they have a high PVR, meaning a large amount left in their bladder after they urinate when we check, if they don't have that good hand dexterity, if they're stuck in a wheelchair or use a walker or just are really bedridden, some of these things are just not good reasons to pursue Botox. But for most people who are otherwise able to walk around and relatively independent with their daily, living habits, it's a good option for them. There is also a risk of urinary tract infection with Botox. How do you counsel your patients on that risk? And is there anything that you do to prevent it, like antibiotics beforehand or afterwards?
Well, I'm glad you mentioned that. I was just participated in a new guidelines for office-based procedures. And so SUFU will be coming out with formal guidelines soon. But basically, if a patient, I don't necessarily give antibiotics to every patient, and I understand if you do, but if we have a suspicion of a urinary tract infection, if they present with symptoms, I'll often check UA, and if it's positive or worrisome for infection, then I'll give them antibiotics into further procedure. For me personally, if there's a risk of recurrent UTIs, I might give them a dose in the office and possibly a few days afterwards. However, if they don't have recurrent UTIs and don't have symptoms, I don't give antibiotics.
Yes, good.
I was just going to say, I think what's so hard in making the decision on what antibiotic to use or to withhold antibiotics is there's just such a poor definition of what a urinary tract infection actually is. And it's almost hard to believe, especially for folks who are not physicians or who have no medical experience, because we know that there is a lot of unnecessary use of antibiotics in the community. And we also know that multi-drug resistant bacteria are a major problem. So when you discuss with patients whether or not they prefer an antibiotic or whether we should use an antibiotic, at first it may seem like a simple answer. Oh yeah, of course, give me an antibiotic. Why not? But then when you explain to them that by giving them antibiotics, and especially if they're not necessary, that it might be increasing their risk of future resistance, and therefore they won't have an antibiotic available to them when they really need it, they oftentimes think about it a little bit more.
So there's two things here. One is the peri-procedure risk of UTIs, and then there's an ongoing, just Botox is contraindicated for patients who have recurrent UTIs because it increases your risk of UTIs like going forward while you have the Botox in your system. So we talk about both of those things. Peri-procedural, it's really institution dependent. You have to look at your own antibiogram. There's no correct answer here because I've participated in this for artificial sphincters. We have done studies on this for every different procedure. I think there isn't clear guidelines. I'm really glad you're going to be providing us with something like this because to me, some of the worst things that bother me are when we do a quick procedure and then somebody's in sepsis, day after, and they're like, "What did you do to prevent that?" So it's a very difficult question to answer. We just need some big scale studies, and having looked at the numbers, the power calculation to actually answer this is like 3,000 patients in per arm.
And
so
Dr.
we
Kim,
really need to look at that.
I was just curious, in writing this guideline, helping to develop it, I'm sure you probably came across a lot of different statistics on the actual rate of a urinary tract infection. Do you think that was more related to the procedure, the use of antibiotics beforehand, or you think it was just based on each paper had a different definition of what a UTI was after the procedure?
Yeah, that's exactly what it is. When we looked at the data, we had some difficulty. We did the best with the available data, but even the definition of UTI, some people were just looking for bacteriuria, which we know by definition is not a urinary tract infection, and they treated those. Part of what was difficult is overactive bladder and your urgency urinary incontinence itself are symptoms of urinary tract infection. So is it that they're symptomatic for UTI, or is it that they just have residual overactive bladder? It makes it very difficult. Hopefully the guidelines will clear up some of that information.
Yeah, and add on top of that pelvic radiation,
Yeah.
right? So these people are already having pathognomonic issues that are consistent with the UTI. And how do you distinguish that from a real UTI?
I think the bottom line is if there's risk factors, it's probably prudent to treat. If there's no risk factors, I don't think it's necessary.
And just to sort of round out the discussion, what are some of the things as a urologist that you really like about doing Botox versus some of the things that you dislike about it?
I like that it's quick onset. The patients know pretty fast whether it's going to work or not. And I like the fact that it can be done in the office. It's a very low burden for the patients to get it done. They can drop in. A lot of times, for example, I'm leaving for the winter to Florida. I can get them in before they leave. What I don't like is sometimes I find it frustrating when we have a stable Botox patient and we do repeats and eventually it wears off. Not sure why that is, and patients get frustrated by it. In the past, we've increased dosages. I think, unfortunately, these days with some new Medicare changes, that isn't as feasible. And the rare occasion that patient goes into urinary retention, it is annoying.
What I really like about Botox is that's one of the only therapies that when it works, it's really just a slam dunk. Usually the patient has improved symptoms, and because the Botox was deposited directly into the bladder, there's just such a minimal risk of any systemic side effects. Whereas other therapies, whether it's oral medications, when they work, there's still usually some degree of patients having side effects. Whether or not they're bothered by that or not is a different story, but they either might experience mild side effects, or they might even just have a concern about side effects based on the systemic absorption of the medication. So I really like when Botox works, the idea that the patient had really targeted therapy to the organ that was problematic for them. What I don't like about Botox is that unfortunate risk of urinary retention. And what I don't like about it is, unfortunately, I do think it does scare a number of patients away. Even when I explain to them that it's just so overwhelmingly more likely that they will be improved by the Botox rather than harmed and need a catheter. It's sometimes just even if there was a 1 in 1,000 chance of needing a catheter, the patient just might be scared away from proceeding with the procedure. So I would say that's a little bit of a downer, just that we probably are not performing Botox as much as probably needed in patients just because of their perceived risk of retention. But of course, we do our best to present the data and hopefully assure them that it's a relatively less common side effect.
Yeah.
I agree with that. Among the what used to be the third line therapies or like the invasive therapies, both. I mean, PTNS is just like so much work, like so much back and forth, so much travel. The sacral neuromodulation and the tibial are both implants, so they're some kind of prosthetic involvement there. Botox, there's nothing implanted into your body, and there isn't that much of a time commitment. So in some ways, it seems like the easiest sort of one-time thing to do. And what I don't like about it is just it doesn't last, so you've got to keep, coming back for it.
Actually, I had to pay a question for you guys. I mean, the fact that it's a toxin. How often do you get patients that come in and say, I know it's a toxin, I don't want that? Because I do have patients like that, and they won't even consider it. They don't realize it's purified and safe.
Yeah, that's a really great point. I've heard of that before, and I've had some patients who voiced similar concerns about the idea that it's called a toxin. But I think what balances that really nicely is that either their friends or their family members might have used the same toxin for cosmetic reasons, and so they feel a little bit better about it and they're more comfortable with it.
The toxins are okay for the face, but not the bladder.
Yeah.
Yeah, it's the same. I mean, it's the same group that'll be, won't vaccinate. So you can't convince people one way or the other. You just provide the information That's data driven and leave it at that.